a 28-year-old male with a past medical history of syncope. So we got to start putting on our chief complaint-based glasses. And he says that he has taken a lot of drugs in the past. So he volunteers that for you. So you already got that out of the way, right? The big pink elephant. And he says, you know, I almost passed out again. So multiple episodes of syncope. I think at some point they thought it was probably drug related. That's not unrealistic in a 28-year-old. But there's one question we need to ask him. And that question is, has anybody in your family died of a young, sudden cardiac arrest, unexplained? Like, did Uncle Johnny die at age 36, but we don't know why? Okay, that's a really, really important question to ask. He says, no, nobody died. And I don't know, I'm probably just overreacting. Okay, so here's some syncope pearls that I wanted to throw out for you really quickly. So get that history. The history matters, especially the family history, and ask about previous episodes. And if so, what did they do about it? So for him, he had previous episodes, normal Holter monitors. So they put in a loop recorder. We're going to interrogate it, don't worry. And family history of sudden cardiac arrest. What were you doing when it started? If somebody's sitting and they stood up, right? We're considering other things like hypotension, but we're not as worried, right? If they're doing it standing up versus just sitting there and all of a sudden they syncopize. And we're also going to use some tools, right? Holter monitoring 24 to 48 hours. Or if they fail that or have more infrequent symptoms, you can do a 30-day event monitor. And ultimately you can implant a loop recorder to have them monitored for 3 years with a little device under their skin, which is what we did for him. You also have to scrutinize their medication list for beta blockers, calcium channel blockers, Flomax, of course, because that lowers blood pressure. And you got to look for antiarrhythmic drugs. And you also have to document whatever kind of provider you are, even if you're EMS, that you told the patient not to drive. Because ultimately, if the patient has syncope and you've documented that, you also have to document that they're not to drive. Now here's the EKG, because of course we're going to scrutinize this like nobody's business, and we're going to look for a couple things. Now I'm going to tell you, with my chief complaint-based glasses, I'm looking for a prolonged QT, which he does not have. It's 373, should be less than 460. I'm looking for a short PR, he doesn't have. We're looking for under 120, and we're looking for any ST elevation. Now you do see that it says he has ST elevation, and so you have to also look at the ST elevation and see where it is. Now, if you look at this, it's not localized. It's actually all over the EKG. We look at the size of the T waves, and you can see the T waves are pretty big, especially in V2, especially in V3. So with that, them being hyperacute, bigger than the dad, you'd worry about ischemia. We had the benefit of knowing that he already had a stress test and it was normal, which was good. Okay. Also, I'd be looking for any, wide QRS or any delta wave, looking for Wolff-Parkinson's White, but he doesn't have that either. So the biggest thing we have is this widespread minor ST elevation with no reciprocal changes. So it's not a STEMI, and it probably actually is benign early repolarization.